Hello everyone, my name is Catherine Mulvaney. On behalf of Lung Foundation Australia, I'd like to welcome you to our webinar this evening. But before we begin, I'd like to first acknowledge the traditional owners and custodians of the country throughout Australia and recognise their continuing connection to land, water and community. I pay my respects to all First Nations people and acknowledge elders past, present and emerging. Today, we're very grateful to have a panel of guest speakers joining us to give us an insight into what it means to go into battle with bronchiectasis. And what's particularly exciting about tonight's event is that it has been designed by bronchiectasis patients based on questions submitted by you, the viewers, and it will be delivered by bronchiectasis patients with the support of key health practitioners in the bronchiectasis space. We hope you come away from tonight's webinar with a better understanding of bronchiectasis, strategies to become and remain battle fit, and some practical insights to start spring on firm ground. Before I introduce our host and panel, I'll just run through some quick housekeeping points. Today's webinar will follow a Q&A format. As I said previously, we've designed the webinar around the questions you submitted, but if you're joining us live, we invite you to submit other questions via the Q&A box at the bottom of your screen. And we're very pleased to have a separate panel available online to answer your questions. I'd like to remind you that the discussion today will be of a general nature only, and our panel will provide no personal health advice. If you have any questions about your individual situation, we encourage you to contact your treating healthcare professional. And finally, I'd like to let you know that this session will be recorded and available for viewing on demand. If you registered for the event, you will automatically receive an email with details to access this recording. But if you didn't register, you can register to get instant access to the on-demand version at any time after the session. I'm now pleased to introduce our panel for today. Presenting live, we have Professor Lucy Morgan, a lung specialist from Sydney and Chair of Lung Foundation Australia. We have Dr. Vikas Goyal, a paediatric lung specialist based at Queensland Children's Hospital in Brisbane. We have Dr. Anne-Marie Lee, a cardiorespiratory physiotherapist and researcher at Monash University in Melbourne. And Estelle McEncrow, a bronchiectasis patient, a peer support mentor, and a member of Lung Foundation Australia's Bronchiectasis Consumer Advisor Committee, and she joins us from the Gold Coast. And answering your questions online, we have another esteemed panel, including Professor Peter Middleton, respiratory specialist and chair of the Australasian Bronchiectasis Consortium. We have Dr. Paul King, a respiratory specialist at Monash Medical Centre. We have Dr. Danielle Wurzel, paediatric respiratory specialist at the Royal Children's Hospital, and Caroline Nicholson, a cardiorespiratory physio, honorary research fellow, and working at Alfred Hospital in Melbourne. And finally, I'm very pleased to welcome Grant Raja as host of tonight's webinar. When you're ready, Grant, I'll hand over to you to introduce yourself and get started.
Yeah, so thank you very much and good evening, good morning, everyone. So to begin with, it's wonderful to have everyone on the call. We have more than 400 registered, so I expect to see that number of people joining grow to well over 100 shortly. But it's tremendous to see that this has gained some attraction to both children, parents and adults with bronchiectasis. So to start off the panel introduction, I'll start with myself. And I wanted to share my story as the host here, but also as someone with bronchiectasis. So I was a child diagnosed with bronchiectasis at 12. It basically means I have about half the lung capacity of a normal person at my age. And as a kid, I barely could run 200 meters, right? So that was pretty tough. As a child, my condition was easily misunderstood, and we'll get into that today in the discussion. But I want to share that over many years, I've developed a holistic plan. I live an active life, and that's one of the key messages for today's discussion, is that with bronchiectasis, you can still have an active and healthy life with proper care. I'm now just a fraction under 50 at 49 and still swimming and cycling. So, and for my contribution to Lung Foundation, I'm on the consumer committee like Estella. And yeah, my goal tonight is to foster a great conversation. So if I can welcome the panel and maybe start with Lucy and then to Vikas, and we'll go through. So welcome everyone.
Thanks, Grant. Hi, everybody. My name's Lucy and I'm a lung doctor from Sydney. I'm passionate about bronchiectasis and I'll talk about it to anyone who'll listen. And as Grant will attest, I'll even keep talking even if people stop listening. I'm really passionate about making sure people know about this condition. There are so many people who've never heard of it. And yet, as we know from tonight, there are so many Australians living with symptoms that are consistent with bronchiectasis. I'm also really passionate about making sure Australians have equal access to really good care for their bronchiectasis. If they have good care and they understand their own symptoms and their own bodies well, then in fact, patients can take really good care of themselves. And we can just be a bit part, we doctors and physios and nurses can be a bit part in the story. So I'm passionate about talking about it, and I'm passionate about all Australians having access to great clinical care.
Hi, everyone. My name is Vikas. I'm one of the pediatric lung doctors from Brisbane. I work at the Queensland Children's Hospital. Like Lucy, I'm very passionate about bronchiectasis. I've been working with pediatric bronchiectasis for more than 10 years now. My main, I think, passion is about early detection of bronchiectasis, because quite often in pediatric patients, the parents are told it's just a cough which will go away. So our main focus is on identifying bronchiectasis early, treating it, and we are hopeful that we'll be able to show that early detected bronchiectasis is reversible in children. And my main focus of research work is on improving the management of bronchiectasis in children.
Yeah, no, really good. And over to you, Anne-Marie, from your experience. Yeah.
Thanks, Grant. So I've been working with people with bronchiectasis since I graduated, which is about 25 years ago now, predominantly in the adult setting, and have also continued to do research sort of within that area. And certainly one of the things that's of the greatest sort of passion for me is trying to make sure that everyone with bronchiectasis has access to physiotherapy, both from an airway clearance perspective and also access to exercise, and trying to develop the most optimal form or combination of different physiotherapy techniques that works for them and works for their family and their lifestyle, and really overcoming some of those challenges and identifying the enablers that will actually sort of essentially enable that to sort of happen for them as well.
Well, I've had bronchiectasis now for 70 years, diagnosed as. So as a child, 4 years old, I had pneumonia, which given the little old half a teaspoon, I needed a full teaspoon, which developed double pneumonia. And then over the years, spent time at the Children's Hospital and then Chermside Chest Hospital with Dr. Morgan Windsor, was my specialist then. And I think the best thing ever that I did, that I was told not to, was keep still. I never stood still, did sports still, and I play golf now. But over the time, when I was 22, I had my lungs, the bottom lobes removed. I just have the top lung on each side lobe. And that's now 50 years on. But lots of things that I'd like to input, and especially children, the fun you can have with exercise.
Yeah.
Over the many years. So that I'd like get more involved in the child side of it. But yeah, even now I go to doctors, I've got to explain what it is and they Google it. So it's that, I think, it's been my biggest problem. Nobody knew what I had, but
yeah. So I will
keep exercising.
Yeah, so during today's conversation, we'll bring up some of those topics for Stella that you and I have seen, and certainly the questions we had, probably more than, I'll hazard a guess, at about 100 questions. So some of those points about not saying still, the simple steps of exercise. Yeah, we'll cover those. And Peter, I can see you, you're there on the chat line, so welcome. And did you want to just introduce yourself and Daniela and Thank you for joining as well.
Well, thank you. Like Lucy, and because I'm a respiratory physician, more for adults than kids. I also do some work at the Kids Hospital. I'd be half as passionate as Lucy because she's much more passionate than I am. But equally, I've done quite a bit of work on bronchiectasis over the years, starting initially with a genetic form of bronchiectasis called CF. Now moving into the other causes of bronchiectasis, which can affect anyone in Australia.
Yeah, cool. Yeah, so to the audience, if you have a question, Peter, Daniela, or others will be answering your comments in the chat. So to dive into the discussion, the first question that sort of came through the questions was really the simple facts. What is bronchiectasis? What are the causes? What are the differences? So if I can start with you, Vikas, from a doctor perspective, let's just, for the audience who has either a child, you're a parent that's just had a diagnosis, or you're a teenager or an older person, let's just describe some of the basic facts around bronchiectasis to begin. Yeah.
So the way I like to describe it to my patients is I like to say that bronchiectasis, like bronchi or bronchus is the breathing tube, and ectasia means out of shape. So when you have your breathing tubes they start to get slightly out of shape, we call it bronchiectasis. But in a more scientific way, when we have breathing tubes or bronchi, which basically are branches of your windpipe or trachea, which divides into right and left, and each then has further subdivisions. And these branches are called bronchi. You could think about your breathing tubes or your airways like an upside down tree, where the trunk of the tree is your trachea, and then it divides into two main branches, and then there are further subdivisions. And these breathing tubes or airways with recurrent infection and obstruction, infection, inflammation, for various causes, when they get inflamed, due to the infection and inflammation, some of them start to get dilated or out of shape, as I said. And what essentially happens is they are in a state of chronic irritation or irritability. We have these glands in these airways, which are called tracheobronchial glands, which their purpose is to secrete mucus. So they produce mucus when you're healthy as well. But when you have chronic infection and inflammation, these glands are chronically producing mucus, which gives you that sputum that you produce. So when you cough, this cough sounds moist. And especially in the earlier stages, when people listen to your chest, your doctor listens to your chest, they say your chest is clear and it's just a cough, it will go away. But quite often, especially in pediatrics, the only sign of bronchiectasis is a chronic wet cough. And in pediatrics, chronic cough is a cough which has lasted for more than 4 weeks.
Yeah, okay. So that's, we'll talk a little bit about symptoms and the effect on children and adults in a moment. Any comments on, the simple bits, the difference between bronchitis and bronchiectasis? That's another question that I saw. So
again, in pediatrics, we believe that it is a spectrum. So chronic wet cough is a spectrum where you start with having a chronic wet cough or a simple bronchitis. The term that we use in pediatrics is protracted bacterial bronchitis, which is again a self-explanatory term that you have a protracted course, which has been present for more than 4 weeks. And there is possibly secondary bacterial infection, and you have a wet cough, which is a sign of bronchitis without any other findings. And so bronchitis is essentially in pediatrics is a wet cough which has been present for more than 4 weeks without radiological changes, without any presence of other signs of chronic illness. And often if you treat this with a protracted course of antibiotics, the bronchitis will get better. Bronchiectasis is a more, when this bronchitis either is not treated or if it is recurrent, sometimes it leads to some damage to your airways or your breathing tubes, which leads to bronchiectasis. So in a simpler way, bronchitis is often the outcome of a acute respiratory infection, and then bronchiectasis is the end result of recurrent bronchitis or a prolonged episode of bronchitis.
And there's some residual damage or scarring of some form. So from
Actually, that's a really important point, Grant. I think
Yeah.
another way to think about bronchiectasis is to remember that bronchitis is just involving the tubes, the pipes, and bronchiectasis does imply that there's some involvement of the spongy lung. So normal healthy lung is like, imagine cutting through a loaf of fresh tip-top white bread. I shouldn't have used a brand name, but it's soft, it's spongy, the tissues are really springy, and there are little tiny bubbles in there. Now, that's normal spongy lung. Now, imagine there's recurrent infection in that spongy fresh bread, and then so the bread becomes a bit more like a crumpet. And you know what a crumpet looks like? The holes are bigger compared to the cake, to the bread. And if you put butter and honey on a crumpet, if it's a hot crumpet, you know what happens? It all ends up going down into the nooks and crannies. And the only way to get it out of a crumpet is to tip it upside down and give it a good squeeze. Okay. Now, you could think about normal healthy lungs as being like fresh bread, and bronchiectasis being a bit of the lung or some parts of the lung that are a bit crumpety. Okay. So now bronchiectasis is just the change, the dilated or abnormal airways. But if you get recurrent infection in there, then you get butter and honey as well, or guacamole or something, recurrent sputum. And you can see that on chest x-rays and CT scans. You can feel it because the cough rattles and you're producing sputum. So that's another way to think about what bronchiectasis is in comparison to bronchitis, which is just swollen and inflamed air tubes without the crumpety bits.
Cool. And Anne-Marie, from a sort of physiotherapy perspective, I guess mucus is a normal thing, but it's sort of the level of it, and as you were saying, getting it out, Lucy, it's sort of, Anne-Marie, did you have a comment on sort of that? So I'm just still trying to describe the condition, right? So I've got bronchiectasis, I'm often clogged up. So how does that trend, how would you describe that sort of symptom or condition? Yeah.
I guess for most people who have bronchiectasis, they do have more, they produce sort of more sputum or have more sputum than normal, and that makes them more susceptible to lung infections, and lung infections also increase the amount of sputum that's within the lungs. And that's why it's so common that people will generally need some form of physiotherapy techniques, so usually airway clearance techniques, of which there's a variety of different options to be able to clear that mucus, and also help manage the secondary side effects of that buildup of mucus that it has on the overall sort of function of the lungs as well.
Yeah, because that's, I mean, maybe to you as well as Stella, I mean, one of the hardest parts for my healthcare has been the regular clearing. And so I do it by, I think, as you were saying, Estella, simple exercise, right? The walk, get out, do some, don't stay still, as you were saying earlier. But yeah, it's not easy, obviously, Anne-Marie, to have a robust routine. But one thing we will talk about further is that once you have this condition, the risk of further infections is quite significant. Yeah, so Estella, any of your thoughts on the general condition?
I remember as starting work, having to go to physio during my lunch break.
Yeah,
my lungs were that bad. But, visiting to the lung hospital over the time was also like I stayed for nearly a month at a time, try and get my lungs back to some level.
Yeah, so we'll talk about managing bronchiectasis and coping with it in sort of the second section. But yeah, it's really important, this point around, one of the questions I saw was, I only need to take medicine if I I've got a flare up or it's excessive. So that obviously, yeah, to you, Vikas or Lucy, that's probably a no-no in terms of managing the condition, right?
Not necessarily, Grant, actually. I think
Okay.
everybody, one of the things about bronchiectasis, in contrast to something like asthma, is that everybody's different.
Yeah.
Medically, we've got a medical word for that, and we call it heterogeneity, but it just means everybody's different. Many people with bronchiectasis have periods where they feel pretty good. They might have a bit of cough, but they might not have any cough. But then there are periods of time when they have a flare up. And again, medically, we call that an exacerbation, but that's just doctor talk. It's a time when their symptoms, their baseline symptoms, get worse than usual. So some people's baseline is really very low. They feel great and they feel really well most of the time. But when things get worse for them, it's that they develop a cough, and usually it's productive cough, a cough with sputum. Some patients, though, have a cough all the time.
Yeah, I do.
And like Estelle, and then have times when it gets worse, so that the cough might be more bothersome, or the sputum might be dirtier, there might be more of it, and it might taste worse, and it might be associated with some other systemic or general body symptoms, like having a bit of a temperature, going off your food, feeling particularly fatigued. So knowing what your baseline is really important, because that will help you to be able to identify before anybody else does that there's a flare up or an exacerbation of your symptoms. That's a really important part of self-management. Knowing what your baseline is, your doctor won't know that anywhere near as well as you'll know it. But not everybody coughs up custard, green custard all the time. Some people do, but clinically significant bronchiectasis is some symptoms most of the time, and worse symptoms from time to time.
Cool. Okay. So, yeah, Vikas, sorry, you were going to say something?
I agree with exactly what Lucy is saying, and
Oh, you should, Vikas.
well, I've learned it, haven't I? But I think in pediatrics particularly, we try to teach the parents that we expect the children to be cough-free, actually. Like once they are diagnosed, once they're treated, a lot of kids achieve a cough-free status, and when their symptoms flare up, they become, and some of them who are diagnosed at a more severe end of the spectrum, they do have a daily cough. But coming back to, the initial question that you asked, that I need to take the medicine when, the way I approach this, especially in the newly diagnosed patients, what I always say to the patients is that consider airway clearance like brushing your teeth. You do not wait till your teeth, your teeth start to get rotten to start brushing them. If you do a degree of airway clearance, age appropriate and depending on your symptoms, then you probably might not, need to. And when they become asymptomatic and in consultation with our physiotherapists, a lot of kids actually stop doing the as much airway clearance when they're well, and they only increase it when they start to have an exacerbation or a flare up.
Yeah, and understanding that baseline and monitoring it, as you both have said, is really important to the ongoing care. So, Kat, if we bring up those slides to sort of share with the audience the profile of the people we have, some of the questions and feedback they've given will really help the panel have the discussion. So maybe if I can throw to you, Lucy, these are the questions and comments that we got from the initial survey. So welcome your insights from that.
Look, I was really just so thrilled that that you took up the opportunity to tell us what really are the challenges for you when it comes to managing bronchiectasis. We weren't surprised to hear that people had a huge, there was a large symptom burden. there's a burden of symptoms from this disease that are really all about recurrent cough and what coughing all the time does to your life, impaired sleep, interruption to conversations, interruption to family relationships, interruption to into workplace and into school, let alone what having a chronic cough does for you in COVID times when it comes to getting a doctor's appointment, going into to pay your car insurance, buying a bottle of milk, coughing. There's been that's an extraordinary thing, and I think we might talk about that a bit more. But we also gathered from your challenges or for your feedback that this is a community of people who carry a really heavy burden of treatment as well. So all the things that we recommend are done in order to keep your lungs clean or empty. They carry a burden. Some of them take time. Some of them take patience. Some of them cost money, and all of them require diligent daily, compliance, doing something every day. So I guess we didn't get terribly many surprises from your feedback about the challenges, but it's really helped us to structure the sorts of things that we feel like you would like us to talk about tonight.
Yeah. And the next slide, Kat. Yeah, thanks.
So this was really interesting. Nearly 90 of you told us where you live and how far you travel to see your doctor. Most of you have a doctor helping you manage your bronchiectasis, but nearly half of you have to travel up to 50 kilometers and to go and see your doctor, and more than nearly 10% of you travel nearly up to 100 kilometers. Many of you who are on the call tonight have to go interstate or more than 100 kilometers to see your lung specialist. So this is really important when we're talking about equity of access, equal access to the next person who needs the same clinical care. So this is something that we would hope that Lung Foundation will be a niche or a gap that we hope Lung Foundation Australia will be able to fill for you. Lots of you knew about our resources, and we're going to talk more about the resources that we hold on the Lung Foundation website in a moment, but many of you did know about the resources, but 40% of you who knew about this webinar had not used any Lung Foundation resources when it came to bronchiectasis. So we would hope that by the end of tonight, you'll know that there's some little gems on this website that might be useful for you. Hopefully you'll also understand that you've got a really important role to play with helping us to refine these resources and make them really useful. So getting involved with Lung Foundation and helping us rewrite things that you think are not written well enough, helping us to pick topics that we haven't covered clearly enough is a really important part of what you can do for us, and what hopefully we can all do together. We were interested that the resources that you found most useful included our nurses on the end of the phone, which was a really important and powerful message about the value of speaking to somebody else who knows about what you're dealing with. So we were really interested by that, and we would hope that we could actually boost that resource. The bronchiectasis toolbox, which I think Anne-Marie will speak to in a moment, was another resource that people had found really, really useful.
Yeah, so thank you very much, and that's a good summary of who was on the call. So just a reminder, if you have questions to the panel and to the people chatting, please post them in the Q&A section. And to Lucy and Vikas and others, you just mentioned about the role the Lung Foundation is playing in awareness and education. So maybe for those that don't know enough about the Lung Foundation, can we have a brief discussion on the mission and its priorities? Then we'll go into a little bit on some of the latest emerging research, if we can tackle that into there. So maybe Who wants to
I'll
start?
take on
there?
the Lung Foundation stuff first.
Yep, cool.
Look, Lung Foundation Australia is Australia's most trusted patient advocacy organisation for all things to do with lungs. We have a really big organisation that's absolutely all here for Australians with lung disease. And I guess we could talk about this for another hour and a half, but probably you could go to the front page of Lung Foundation's website and read about our mission. But we run education for patients, we run education for clinicians, we have a huge advocacy role and with policy advocacy to government around policy around lung disease in all sorts of different avenues, all sorts of different diseases. We're all about safe workplaces, about safe air to clean air to breathe, and clean places for our kids to play and grow up, clean places to work, and then early detection and management of all sorts of lung diseases.
Cool.
There you go.
And Estella, you and I are both on the consumer committee, so maybe share the role that you play in that, and then I'll jump into the research, maybe to Vikas and others. So, yeah.
I've had a chance to speak to people that are asking for support or just knowledge, and the situation is you give them a phone call once a week at whatever time suits them, and just run through like their lifestyle and what they're having problems with and what they're not able to understand from trying to read up on things, which gets very, you go on Google with it and it's like mind-boggling. So it's been helpful for me to be able to sort of explain to them their situation and how they can maybe improve it at different lifestyles that they might not be achieving. And yeah, so I've had different people over the time and just been able to talk to them, and for them too, I think knowing that they're talking to somebody that's like them, I think that was not, it wasn't a joy, but it was for them, it was very, very important. They can go to their GP and their GP has to Google it. That was one lady's comment.
Yeah.
He literally said, go away and come back, I'll Google it. He had no idea, which is a shame, but lots of little tricks and that you can do over the time that will help.
Yeah. Well, that's, exactly. So that's what the committee's for, is to provide that consumer face side to what it's like as the person with bronchiectasis. So just on research, I know that's a whole other big area, but there were questions on what's emerging. Where is research focusing in terms of the care of bronchiectasis for both children and adults? So Vikas, did you want to make a brief comment on that?
Our research group is doing a fair bit of research. The three areas that we are focusing on at the moment is, one is, as I said earlier, to define whether bronchiectasis in children is reversible, and identify which ones are, like, what defines the reversibility. The other big area that we are looking at the moment is interventions which can decrease the number of exacerbations or flare-ups in children with bronchiectasis, including some of the newer drugs, newer medications which are not available in Australia yet. We are running some randomized controlled trials, some of them with adults as well. I keep hearing the theme of don't sit still and being active from both you and Estelle. So we are actually running a randomized control trial looking at the role of a structured exercise program, whether it will improve the number of exacerbations that children have. So, simple things like activity, does it actually help, and how much does it help? And the third thing that we are focusing on is trying to define different types of what we call phenotype in medicine. Basically means that you have a genetic makeup like you and, for example, if you have a twin brother, you're genetically exactly similar, but you might have different personalities. So because bronchiectasis is such a heterogeneous condition, a lot of things cause bronchiectasis, and each one has their own baseline and their own symptoms. We are also trying to define a bronchiectasis in a better way in children, to see which are the ones who have more flare-ups compared to the ones who have lesser number of flare-ups, how the children who have more severe bronchiectasis, how are they different from other ones, and do they need a different approach? So we're working on all three aspects. One is identifying it early, and then reversibility. Second is managing the symptoms more, I guess, in a way that you have less flare-ups, so interventions which lead to less flare-ups, and then to actually nicely define various symptoms and clinical profiles to see what type of patient you are and what's, so that we can individualize the management. And staying on that theme, we are also looking at a standardized action management plan for children with bronchiectasis, whether that helps and empowers them to manage their symptoms better.
Okay, so really good. And I know, Peter, you're focused on the chat, but did you want to add anything, or you're okay on the research front?
Well, I'd support everything that Lucy Vickers has said. The difficulty is that there are so many different types of bronchiectasis. There are so many different diseases or disease propensities that can actually end up giving you chronic infection inside the lungs. And so the difficulty is, as doctors, that there aren't really sort of a single sort of disease that fits with bronchiectasis. And in a way, having a mechanism to actually divide out those people who have bronchiectasis due to this gene or due to that gene, things such as cystic fibrosis, or people who have immunodeficiencies, or people with primary ciliary dyskinesia, where the little hairs on the inside of the airways don't quite work properly. All of those things can give quite significant bronchiectasis to people in early childhood or in adulthood. And trying to work out what works for one subtype of bronchiectasis can be really quite important. And it's not a case of every treatment that we can offer works for everyone equally. And much of this has to really be individualized for that individual, for where they're up to, for what their lung function is like, for what their physiotherapy and exercise capacity are, and equally what sort of bugs are down inside the chest. Because if the actual environment, the bugs that get inside your chest can actually drive the process to quite a large extent. So everything has to be really individualized, and it can't be just a one-stop shop that everyone gets the same thing, because there is just so much difference between different people.
So that's a good takeaway.
Individualized, isn't it? It is individualized, Pete, but there are some red flags for us, aren't there? So there are some patients, the patient who has Pseudomonas aeruginosa, that's the name of a bug. People who've got Pseudomonas in their airways do have a different journey or a different tempo to their disease, a different symptom burden to those who don't have Pseudomonas. And that's one group of patients with one specific bug who seem to behave or seem to have a different experience with their bronchiectasis compared to those patients who don't have Pseudomonas in their lungs. So eradicating Pseudomonas is one of the things that's been a holy grail for us, to try to eradicate that bug. And I notice in the chat, there are several people asking about Pseudomonas. It's a bug. it's what we call a ubiquitous bug, meaning it lives everywhere. It's in the water, it's in the soil, and it doesn't cause problems if you've got healthy, normal lungs. But if you've got bronchiectasis, it can get into the lungs, it can get into the airways, and it's like a squatter moving into a terrace house in Paddington. It'll have a party, they'll have parties, they'll have babies, it proliferates, and it can be a marker, and it's definitely a marker of more rapidly progressive symptoms. So sometimes treatment is designed specifically to get rid of a bug, to try and get rid of a bug. And almost always treatment options are aimed at reducing the number of flare-ups for every year, which probably leads into the research bit, because we're always looking for new ways to kill bugs that are resistant to the current antibiotics we've got. We're always looking for ways to reduce exacerbations. And there are some new drugs on the horizon in the pipeline that are actually aimed at treating the inflammation that's happening in airways, not just trying to kill bugs. So there is a lot of optimism actually in bronchiectasis research at the moment for new ways of treating this very, very old-fashioned condition.
Cool. So thank you for that discussion. And just to give people a heads up where we're going. So the next section is about being battle fit, right? What are the two things that came out of the discussions in the question was there's a lot of misconceptions. There's a lot of lack of awareness. So we'll talk about those 2 points. Then we'll focus on practical things around ongoing management and the tools to end, with a constructive, optimistic way forward. So to begin with, if I open to the panel, like our community, and this is something that came out strongly and I see it, our community is super sensitive. And when I mean that, the great out wide world is super sensitive to anyone that has a cough or a wheeze, right? I walk into my office at work and they'll hear me wheeze and they'll say, oh, do you have COVID immediately, right? So, and years ago when it was just common, or that they'd go, is it contagious, right? Or, there's all of these perceptions out there that are driven by a lack of awareness. And so I'm really conveying that is the battle that people with bronchiectasis face, right? Whether we're a kid at school or at work or anywhere in the community, it's really tough. So I just wanted the panel to talk through those misconceptions, and I'll go around to everyone on this one, I think. So yeah, who wants to start? Estella, yeah, you share the same view in some ways.
And that what Lucy was just talking about, I didn't know how to quite pronounce, but it's on my list of the culture that I got back from my thing. And apparently I've had it for quite a while, which I didn't really. Every time I get a culture done, I come up with a different word. It's a different thing. I'm thinking now they're just plucking them out to think, oh, well, she's got this one now. But
it's alphabet soup.
It's and it's not a good one, which I got told by the heart specialist the other day. And I think, oh, really? Oh, well. I've had it for quite a long time, and I'm still here. So, but at school, my mum used to save me this small roll of toilet paper so I could take to school, because we didn't have boxes of tissues back then. So, and I didn't get calls nice names. Pussyface was one of my favourites, I guess, at the time. It never fazed me, because I was still out there playing cricket with the boys in the morning and then swimming in the afternoon. So I think to me, it was never a problem. And also being young and in hospital with a lot of people, I just realised I was actually the one running around in hospital, because I was never bedridden with it. They were all bad asthmatics and a couple of little heart patients and that. So I was quite lucky with what I had, sort of, because I was
yeah, we have a similar story then. I was in hospital platoon 2 and 3.
What my mum did at home, I had 3 bricks under my bed, and I was elevated with my head down till I was 15. So that to me was something that I think you can do from home, and that's 8 hours of drainage that you get as well. And that was ongoing, not if I was bad or good.
Yeah, so you have to be really resilient, like you're saying, Estelle, to sort of battle through that. And
Yeah, it was,
yeah,
my glass is always 60% full. So I always,
cool. So to the others, like one of the misconceptions that I saw in the questions to you, Anne-Marie, was, oh, I shouldn't exercise because I've got bronchiectasis.
Oh,
And I
gosh, no.
think, yeah, and so Anne-Marie, I think you've got a strong view on that one, but yeah, welcome comments on that, because
yeah, I think the role of exercise is, has multiple benefits. So certainly a lot of people would find that doing exercise is what actually helps to clear the phlegm from their chest. Particularly works well for people who have probably smaller amounts of exercise, and they might find that, just going for a 10-minute or 30-minute sort of walk in the morning, or swimming like Estelle says, or just maintaining exercise or some kind of physical activity is enough to keep their lungs sort of clear and manage it sort of through the day. I think the other thing around how to cope with some of those misconceptions and the stigma that can come with cough, some of it might be related to what education others around that whether it be at school or at sort of workplaces have, and whether people are comfortable sort of explaining that in terms of part of their condition. But it also might be in terms of looking at the timing of when you do your airway clearance. So if you can work it in sort of either before work, or choose techniques that are able to be done sort of at work, like exercise, or quietly going to the bathroom to do some ACBT, or I know some people who go out to the car to use their PEP therapy sort of in their lunch break, and just using some of those other sort of mix of strategies, particularly to cope with, I guess, avoiding that sort of prevalent sort of cough that people are going to be sort of noticing, and people are particularly sort of aware of that. But also to help sort of feel less congested sort of through the day. So there's some tips for those who do find that there is a build-up of phlegm and there's a need to do those sort of techniques, but having, I guess, a variety of options available to you and picking the ones that work best in those different circumstances can be a really important way to tackle that.
So thank you.
Over the time, I think from when I was really little, my biggest problem was I'm allergic to penicillin.
Okay. Yeah.
So back in the day, that was the magic.
That was the main medicine.
And
then,
I think probably then I would have maybe got over it. But having that all the time, it was very hard for the doctors to try and work out what they were going to give me as well. And
you touched on the challenge you faced and others of having to remind a doctor or talk to a GP, and there were comments in the questions about, I see a different GP each time and I have to basically explain my condition to them. So to a medical question, if I can ask it in one form, is bronchiectasis well recognised, or is it under-recognised? Is that the way to put it, Vikas, in the medical community, or how would you tackle that sort of question?
So I think the best way to look at it is looking at the history of bronchiectasis. So bronchiectasis was very well first described in literature in 1819 by a French physician, RTH Laennec, the same guy who invented the stethoscope. But the first description comes from the autopsies of some patients that he was following through. And I guess in the early 20th century, bronchiectasis was well recognized and was well treated, not necessarily well treated, but was well recognized and was always a differential diagnosis in minds of people, because tuberculosis, whooping cough, and measles diseases like infectious diseases were quite common, and some of them would lead to bronchiectasis. But with improvement in hygiene and with vaccination and the burden of these diseases coming down, there was a period in medicine where bronchiectasis was assigned to the category of orphan diseases, which kind of rare diseases. And there was a survey done in US in around early 2000s, where most of the pediatricians said that they had never diagnosed bronchiectasis in their life. So but in last 20 years, I would say, especially in Australia, a lot of work has been done in this space. A lot more GPs and pediatricians are aware of the diagnosis of bronchiectasis, and it is a bit of a cultural change as well. So it's now being emphasized, and chronic wet cough and bronchiectasis and pediatric bronchitis is now taught in the medical school and in their pediatric training as well. So there is some positive changes happening in that space.
Yeah, and if I maybe just as a comment, Lucy, I'm happy if you wanted to dive in on this, but in a negative and a positive sense, I guess the awareness of COVID and things has made us all very aware of lung conditions, right? So while it has been ignored, I personally get asked almost every day, do I have COVID, right? But I'm happy to say, no, I have a diagnosed condition and this is how I'm treating it, and don't jump out the window and run away, right? It's safe and I'm looking after my own health. So I think everything that the Lung Foundation does and what we can say in our own life about this is an understood condition. But yeah, Lucy, help me here a little bit. It's sort of like it's the awareness isn't there widely, right? It's misunderstood is what I'm trying to say. And people jump to the conclusion that it is contagious. But as soon as they ask that question, which I think they're willing to do today, I think people want to know, like if I cough, I have to disclose, if I go to work, I have to disclose if I have COVID, but I'm sitting next to people managing my condition. So the awareness is there, and the acceptance of it is quite good, I think, but we have to. Yeah.
Look, I think there's a temptation to get very negative about COVID and about I think very negative about dealing with a chronic lung condition in a COVID world. But there are some significant positive reframes on this. One is that never has our community been so conscious of lung health. Honestly, never have there been so many experts in lungs, 19 million of us, all experts. COVID has made us as a community acutely aware of the potential and the power of the respiratory virus, okay? But it's also taught us as a community about the power of washing our hands regularly, of not giving each other a deep and intimate embrace when we've got a temperature and a really, really runny nose, and of what we can do to reduce the risk of transmission of respiratory viruses. People with chronic lung disease have always been vulnerable to flare-ups induced by catching respiratory viruses. So the common cold is the most potent of triggers for a chest infection. Influenza in other years, until 2018, killed 1,000 Australians every year. Many of them older, but many of them very, very young. And influenza, RSV virus, the human metapneumovirus, coronaviruses, of which COVID-19 is one, are very, very potent triggers for flare-ups for people with chronic lung disease. So I think the positive reframe is we now know how we can protect ourselves from, minimize the risk of catching viruses. And it's by simple things like washing our hands and the cough etiquette of not sneezing and coughing all over somebody when you've got a virus, and of staying relatively isolated from intimate contact with people if you've got a virus, staying away from work rather than soldiering on, not going to daycare when you've got a very high temperature and a runny nose, not going to grandma's if grandma has a chronic lung condition, or to aunties or uncles or brothers or sisters for that matter if there's a chronic lung condition. So we've learnt lots. Not everything that coughs is COVID. Another flip to that, and another positive reframe of that is I would hope that we are getting better and better at recognizing that chronic cough is not normal and that deserves a name and an explanation or a diagnosis. There are some really tricky conversation. There are some really tricky aspects to that in a post-COVID world. Many GPs are still reeling from the pandemic, from the big waves of the pandemic. And I have heard many patients tell me that they can't get to see their GP when they've got a respiratory symptom. So that's very problematic. And I really, I think we've got a lot of work to do about that. But the positives are that I think, chronic cough is not normal. It's not always, but this is a group of people who've got a diagnosis of bronchiectasis, all the people that we're talking to tonight. So,
and I guess the message in all that is we can be battle strong to face that challenge. And I do agree that the people that are out there, they're aware of it. Hygiene, wearing masks is way more acceptable than it ever has been.
Yeah.
So one quick comment to keep to time. There was a simple question, which I think is worth asking. Is there a specific treatment I can request from my GP if I get COVID? So I think many people know the answer, but in our case, there is a special option, right? So Nicholas, did you want to comment on that?
If you are asking for specific treatment for COVID in children with
or children or adults, so because we've got a chronic condition that affects respiratory.
So so far in adolescents who have or pediatric patients who have bronchiectasis and who meet certain criteria, they are eligible for antiviral treatments. And some of the other patients who again are more unwell and have more significant disease, there is another drug called Evusheld, which some depending on if you meet certain criteria, then you are eligible, which gives you protection for next 6 months.
The key, because I got COVID back in July and I didn't really know much about it, but as soon as I spoke to my GP, the antiviral was an option. So
this is that's actually going to change. It changes with time. It changes in different states. I think the most important message remains for this audience remains that adequate vaccination against COVID, as well as other vaccine preventable illnesses, including influenza, remains our shield, our suit of armor to protect us from severe viral illness. And when you've got bronchiectasis, that's a really important part of your battle plan, whether you're a small child who's still having their age-specific vaccines, or whether you're an adult or of any age, vaccine preventable respiratory viruses is a really important part of protecting yourself every year and throughout the year. And it's much more important than the details of antivirals, I think.
Cool. And looking at this same sort of discussion around managing and coping with bronchiectasis, a lot of people ask questions about the critical stage of managing a flare-up and what to do and the simple steps there. So maybe from a physiotherapy and a medical background, maybe I'll pass to you, Anne-Marie, is so, describe the condition. You touched on it at the beginning, but what does someone do when they have a pretty significant flare-up from your perspective?
I think that the key thing is that if they've got a physiotherapy routine, there may need to be alterations in that routine. So it might be that some techniques that they normally do to help clear the phlegm from their chest are too hard for them. They actually make them breathless or cough a lot more. So they may need to draw on other sort of strategies. And they also might need to perhaps, rather than doing a 20-minute or a 30-minute session, they may need to do shorter sessions, but a little bit more regularly to conserve some energy, but also to sort of just manage the increase in secretions and the other symptoms that come sort of alongside of that. I think the other thing that's really important when you have a flare-up is, or that's also important when you're stable, is maintaining good hydration. So staying well hydrated, certainly keeping up your fluid sort of levels, drinking lots of water, as long as you don't have any other restrictions, is something that will also help to reduce the thickness of the phlegm, something that's quite easy to do. And if that's one of the changes that you're noticing, then that's one of the things that can actually make the rest of your airway clearance that little bit easier. And that also extends for, if exercise is your normal routine when you're well, then it might be that you can't perhaps do the same volume, but there may be other sort of options around that to enable that to work for you.
And Stella, your perspective as someone as well who's probably had many flare-ups as well?
Well, I do probably have about maybe 3 a year. I try to try not to have one, obviously, but because of my volume of antibiotics that are available, I'm getting down to, I've got 2 now maybe. So it's getting pretty scary there. But I am actually getting another pneumonia injection, immunization. And apparently it's new out there. So that's coming up next week. Not by my doctor, by another one that I certainly went and saw. So that's a good thing. But just trying to keep up on exercise with the children, and those bubbles that you've got to blow in and keep the 3 balls up. They would be fun for the little ones, and they should have them playing around to play with, have competitions with their siblings, things like that, because I find that I get my flatmate to try and do it, she nearly conks out on me. So
yeah, that's actually a really point that Vickers, I'd like you to comment on, is the importance of, it's probably more general than just flare-ups. It's looking after the lung health of children as they grow up, right? So your lungs are developing, what's your comments on managing bronchiectasis, especially as a child, beyond the physiotherapy side that we've just talked through? Yeah.
So
sorry.
You go first, Esther.
I was just going to say, my biggest problem growing up and lack of knowledge from doctors, etc., was the fact that I was finding what not to eat and drink to help my phlegm not being produced so well. And milk, dairy would have to be the worst thing that I would have been having as a child.
Cool.
To just even at school, we used to get the little bottle of milk. You have to drink it, and I go, well, I can't. Well, that's ridiculous, Mum ended up having to come up to the school.
So to build on that, we'll talk about the sort of the 4 pillars in a moment, but the holistic, so diets and food is in there. So thank you for bringing that up. Vickers, your perspective from the protecting the health of a child as they grow with bronchiectasis, how would you describe that?
So I think in general, the things that we'd like to focus on, not just airway clearance, is, as I said earlier, that we try to get the children to a cough-free state if we can. And so we would like to believe that all children with bronchiectasis, especially when they're well, are cough-free. So, but we try to incorporate age-appropriate airway clearance therapy for all of them, and it doesn't always have to be a PEP device or percussion on the chest. Some of the little ones, we use those party trumpets, which, it's like a plastic whistle with a piece of paper attached to it, which gives you headaches, but it teaches them to blow against resistance and helps keep their lungs clear. Things like wind instruments and brass instruments.
That's something I've never heard in all my time, the idea of blowing a French horn or something.
I love that. If your kid's got bronchiectasis and they say, I want to join the band, just don't let them do a violin. Make them play
it's a really good insight. And Peter, I saw you had your hand up. I missed you earlier. Did you want to say something to this discussion?
Yes, it was actually a couple of topics ago when Lucy was very elegantly talking about the viral risk of us all going backwards and forwards. I think it is worthwhile saying that in Australia, there's very little tuberculosis, but many countries around the world, there's still quite a lot of tuberculosis. So people with a chronic productive cough in other countries will be thought as suffering from TB, which is transmissible. The difference for the cough in bronchiectasis is that the vast majority of the organisms that grow in the airways don't transmit to other people. Now, the virus is obviously, if you do get COVID, then you could give it to someone else, just like I could give it to you. But the bugs that grow in your lung, as Lucy was saying, the guacamole there, it actually doesn't grow in my lung. And so you are not a risk, not contagious, not a problem for anyone else, because your bugs don't grow in other lungs.
And I find a lot of people understand my condition when I give it a name. So, you know, it's not COVID, it's bronchiectasis, and so that's okay. So any other comments on, you know, this, Vickers? Did you?
I was saying that airway clearance is only a part of looking after children with bronchiectasis. What we like to, you know, I think what we try to aim for is that when we transition them to adults, they have a normal lung function. So it's not just airway clearance. We try to decrease the number of flare-ups they have, and if they have a flare-up which does not respond to oral antibiotics, we try to be more proactive and use or more aggressive towards treating it and admit them for IV antibiotics and physiotherapy. And I think our bigger aim is to, as I said, to transition these children to adult clinics with a normal lung function if we can. And other things that which we often discuss in our clinics is maintaining good nutrition. And when I say nutrition, it's not about just having weight gain, or it's more about maintaining an optimal health nutritionally, because children, especially when they are well and when they are going more towards a healthier weight and good muscle mass, they tend to, tolerate or cope with the flare-ups or the viruses better. We often see.
So let me jump into that sort of holistic discussion, because you're touching on, because the points around diet, we've talked about exercise. So maybe, Lucy, if I can throw you into the 4-pillar discussion, if you're ready. So it's sort of, and I'm trying to keep everyone to time, so.
Okay, so that's code for don't talk too much.
No, not to you. I've just got two more things to cover.
So the 4 pillars that Grant's referring to is of course not quite correct, because every time we have this conversation, I realize there's another pillar, but it's the idea of foundation issues, like kind of core issues that hold up health when it comes to bronchiectasis. And it's really about maintaining healthy lungs, but in order to do that, maintaining a healthy body in other ways and a healthy mind. So you could say there are 3 pillars, but then of course, once we get started, you'll realize that there are so many more. So it's the idea that we can't that we are whole people, and to take a holistic approach to feeling well as an Australian who happens to have bronchiectasis. We do want to have lungs that are as clear of mucus as possible, that are as free from exacerbation and infections as possible, and that where the lung function is as normal as possible. And so anything we can do to have those, whether it's be airway clearance and exercise, whether it be vaccines to prevent viruses that cause exacerbations, whether it's about treating flare-ups when they occur with antibiotics that are specific for the bugs that are growing in those lungs, and whether it's about treating an underlying airway problem such as asthma, which can coexist for some patients with bronchiectasis. That's the lung bit. And then we've got the rest, because we've got this cake or this crumpet sitting in the cake tin of our chest wall, but it's connected to the rest of our body. So it's about having a gut that's healthy too. Because lots of antibiotics sometimes muck around with people's guts. So our microbiome gets all out of whack. So that's about thinking about what we eat and thinking about what we drink. So it's about healthy food, about whole food, about minimizing processed foods and fast foods, and about having regular and large portions of fresh fruit and vegetables, some smaller portions of grains, and some protein, because we need to fuel this body of ours that's carrying around our lungs. And so that's where sometimes dietitians can really help us, professionals who understand about nutrients and energy and the balance of foods that we need to eat to keep healthy, to be healthy. So and thinking about nutrition as part of that, as fuel for the body that's carrying around the lungs, is really, really important when it comes to maximizing our immunity, so our ability to fight infections, maximizing our ability to cope with having to take antibiotics, which we need for the flare-ups. So that's about reducing tummy upsets and grumbly tummies and diarrhea and tummy pain, which can really occur very frequently, especially when you've got to have antibiotics a lot. And especially if you're a little person who's having antibiotics a lot. We also want to make sure that we have strong bones. And as we get older, and particularly if we've got chronic infection and are having lots of steroid medication through our lives, our bones can get thin. And if our bones get thin and weak, they can crack, they can cause pain, and then you're not as mobile. And then the cycle, things collapse a bit. So maintaining nutrition and weight-bearing exercise is really important for bones. Exercise is good for everything. And Anne-Marie is going to interrupt me in a minute and tell us the science behind it. But exercise keeps our muscles strong. It helps us think better. It helps us sleep better. It helps us be happier and more content in our lives. And it helps us keep our lungs clean. So the healthy mind, healthy body, healthy lungs connection. That's what we're getting at with the 4 pillars.
Yeah, cool. So Anne-Marie, the whole idea of beyond medicine, for me, the revelation in my journey was treating my whole body, not just the medical bit, right? So as soon as I thought of the breathing, the exercise, and even the diet, the foundations made a difference, right? So, but your mantra on breathing, it's still something that I don't do perfectly. I'm hopeless on the regular routine of better breathing, but your guidance or comments on that, Anne-Marie?
I think one of the most common things that we can see for people who have bronchiectasis is that because of their constant sort of awareness or need to cough, is that, to try and sort of avoid that, they'll often, sort of change their breathing pattern and essentially breathe above their phlegm. And that can create problems that we call breathing pattern disorders. So basically people aren't taking deep breaths on a regular basis. And that could essentially mean that they're not actually getting the air down to the lungs to enable them to clear the phlegm that's there, but also to get the benefits of sort of exercise. So I think that the key message is
more breathless, Anne-Marie. Sorry to interrupt. Can that lead to people actually feeling more breathless if there's muck down there and they're breathing above it?
Yes. So essentially, the key is to, if you're going to see a physiotherapist, that they also assess, your breathing pattern to determine whether you're breathing from the upper part of the chest or whether you're actually and breathing above the phlegm, or whether you're actually getting the airflow sort of a little bit further down where you want it to be, and be able, if there is an issue, to institute different sort of strategies or breathing sort of techniques that will correct the dysfunction that's actually sort of there. And that can go alongside, the airway clearance side of things as well.
Yeah.
And I guess the other thing with airway clearance is that anyone living with bronchiectasis is the expert. So you know what it's like in terms of the behaviour of your phlegm, when you feel congested, when you don't feel congested, what techniques works, what don't. And so it's really important to have that partnership with your physio to be able to work out what is the best routine for you, and what does that look like during the day, and what does it look like or need to look like when you've got a flare up, and being able to sort of manage that and basically switch and change things around as needed, bring in different combinations of techniques, because sometimes you'll need other things, and then you can go back to something that's more simple, depending on what's actually sort of going on.
Yeah,
Can
cool.
I just add something on that, Gwen?
Yeah,
When I was in hospital as a little league, they used to put a glass of water on our chest and made us breathe with our belly. Which
cool
I still do.
prove that. Yeah, awesome.
So is that me getting underneath my?
That is you getting underneath your phlegm. So I'm glad that they were thinking of that technique.
I was a couple of months pregnant because my stomach muscles were so overdeveloped.
Yeah.
But it's never fazed me, but I still technically don't breathe with the top of my chest.
Yeah, and I'm probably the same.
I'm just watching it now.
Yeah.
I'm going, okay, I'm still doing it. Sorry.
So we've covered a huge amount of topics, and obviously there's lots of other questions that people wanted to ask in the questions. To close in the next 10 minutes or so, Kat, if you can bring up the tool, the access of, the library of resources and information, then I'll ask who should talk to. Estelle, you might know many of these materials, so maybe I can start with you. So the idea here is that while we've only scratched the surface today, there is a wealth of information that we've touched on here. And so maybe Estelle or Lucy, if you wanted to run through a couple of these documents that people can access on the Lung Foundation webpage.
Oh, actually, I haven't even looked at this before.
That's cool.
And maybe Lucy, but at the end of the day, I think, as you were saying, each of us have a different strength to cope with our bronchiectasis. But I think having these action plans and things like that is a good input, because at least you can go through it and think, well, that's me. No, I don't do that. So I think overall, it's a good thing to have as another tool to.
So just so everybody knows what is available, because we know from our little survey before this that nearly 40% of you didn't know we had some things for you on the website. So we've got several different documents. Just on this page, we've got one that's called the My Bronchiectasis Checklist. So this is a very, very brief document. It's one page, and it's the page that you take to the doctor who doesn't know anything about bronchiectasis. Okay, very, very. Most people's GPs will might have one or two patients at most who've got bronchiectasis. So we've got 400 Australians with bronchiectasis online tonight, but each GP out there is likely to have one patient. So you can become their bronchiectasis expert. The checklist is something for you to take to your doctor to help with the conversations that you need to have with your doctor. And it's just an aid memoir. It's to help you to remember the things that are important to talk to your GP about. So have I had a CT? How do I know I've got bronchiectasis? Well, to make the diagnosis, you need a CT scan. So a CT scan is the way that you diagnose bronchiectasis in someone who's got a recurrent cough. So that's what that question is about. Then there's a series of 5 or 6 questions that just help you to tailor a conversation with your GP. The My Bronchiectasis Action Plan is slightly different, but it's also for you and your bronchiectasis doctors to make to fill in this, print it off and stick it on the fridge with the magnet from the plumber. Okay, so it's a way of writing down what your baseline symptoms are, and then what do I do with my baseline symptoms get worse? And it's got a very simple sort of traffic light, green, amber, red template, green being the Lung Foundation's favorite color. So that's what things are like when they're normal, and it's a hunky-dory normal Monday. But if things are worse than usual, then that's an amber. And so it's a way of documenting what do I do if my cough gets worse or my phlegm changes from clear to yellow, for example. And you set this out with your doctor. What am I going to do if I'm well? What am I going to do if things get worse? And then if my symptoms have changed a lot and I'm worried, that's the red bar. And then it's call the ambulance, do this, do this, do this. And if it's all written down there and it's on the fridge, then other people in your house can help you to remember what you need to do. So that's what the action plan is for. That can be updated with your doctor if treatments change. There's a third document that is more for clinicians. So it's more for doctors than for patients, but I think it's really useful for patients to understand what's in this document. It's called a stepwise management plan, and it's to help doctors understand what the evidence suggests patients should have in terms of treatment, depending on the severity of their symptoms and the frequency of their exacerbations. So basically, everybody, whether you've got mild, moderate, or severe bronchiectasis, everybody should have daily physiotherapy. That's what Anne-Marie was talking about before. Everybody should have physiotherapy that's tailored to them. So some airway clearance, just like brushing your teeth, boring, but every single day, in order to prevent things getting worse. But then patients who've got more severe disease will qualify for some other treatments, and people who've got a very heavy burden of symptoms with lots and lots of exacerbations will need different treatment again. And that's what that stepwise management document is all about. You're allowed to look at it. It's not secret medical business, it's your business, but it's just a tool designed actually as an instrument for clinicians. So there's another fantastic resource on the website, and this is where we're going to hand over to Anne-Marie, because one of the most important documents it includes the bronchiectasis toolbox.
Thanks, Lucy. So this is a resource that has a number of different sections in it, and it certainly talks about what assessment procedures are done for people with bronchiectasis from both the doctor perspective and the physio perspective, but it also has the different airway clearance options and the benefits of exercise. And there's some fantastic videos that basically give an outline. They're nice and short, probably no more than 4 minutes, of the most common techniques in terms of airway clearance that people would do. And it's available to be sort of review these sort of resources as often as you like, so that you can certainly check your technique in between going to see the physiotherapist. And that's one of the great sort of benefits of it as well. The other thing it also highlights is that we're certainly aware that doing airway clearance and exercise does come with some complications. So, for example, incontinence can be an issue with lots of coughing, and musculoskeletal pain can also be an issue. And so there's some tips there as to how to get that assessed and what options there are for treatment of that, those particular symptoms, to be able to still do the physio that's actually sort of necessary on a daily basis. The other website I'll just highlight. Oh, sorry.
Yeah. No, please go in. Right. Yep.
I was just going to highlight the other website, which is the newer one called Strong Lungs, and that's got some very specific resources for our First Nations Australians. They come in a number of different languages, and again, those videos are available to be sort of viewed, and there's also some exercise sheets alongside that as well.
So just in closing, so I'm going to try and wrap up really quickly. The thing we wanted to leave the audience with is, it is the 1st of September, so it's the start of spring. And I thought it would be a great chance for the panel to give one practical, simple thing we all could do. And then Kat will close out Kat has all of the links to the material we just ran through to share with everyone on the audience. So from my end, thank you very much for participating, and maybe I'll start with you, Anne-Marie, and we'll go around the room, and then Kat, you can close it.
So the tip from me would be to look at doing some exercise as part of your day and regularly check in with your physiotherapist to make sure that your technique is working the best it can for you.
So Estelle, and then...
Well, I was looking also to try and get your nutritionist to absolutely tell you what does not build mucus up.
Cool.
That to me as a little was probably the hardest thing Mum had to deal with.
Yeah, cool. And Vikas,
and you have to educate them first.
yeah, and
because they
explain to
have
them
no
why
idea.
you're asking for that special
I
diet.
mean, it's all good bones and everything, so have plenty of milk. Well, that was terrible for me, and it
Yeah,
is
no.
for anybody with mucus. So
Yeah, so cool.
yeah,
And
to
Vikas, your perspective on a simple tip for maybe the child. I know you probably had a thought already, but any simple tip?
What I always say to the patients, because it comes as, you know, new diagnosis of bronchiectasis can be quite overwhelming for the families. So I always say, once things settle down, do not forget, do not let this condition describe your child. You have a child who has a medical condition, and, you know, with diligent management, things will stabilize. So I think that's my main message to most of the patients that I see, that, you know, do not let bronchiectasis describe or define their life.
And Peter, did you have something you wanted to add to that sort of comments?
Sure. Like Lucy, I could talk for quite a while on bronchiectasis, and there's so much we haven't yet covered. I think the take-home message is that you do need a GP, a specialist, and in fact a multidisciplinary team to really get the best out of your health, to deal with all the facets of bronchiectasis and to keep everything ticking over properly.
Yeah, no, that certainly made a difference for me. So Kat, your turn, and we can...
Okay, well, I just want to say thank you to everyone for joining us for tonight's webcast. I hope you all found value in it, and what we've discussed will be helpful for you as you navigate your own battle with bronchiectasis. And I want to say thanks to our fantastic panel for sharing their wealth of knowledge and experience, and for their such insightful answers. And finally, a big thank you to Grant Raja for leading us in such an interesting discussion. It was really fantastic. Thank you, Grant. And to both Grant and Estelle for giving us insight into how they manage their own battle with bronchiectasis. And then I'll just leave you, I'll just refer to a couple more slides, just to say that before we close the session, I want to take the moment to direct everyone to the resources that Lung Foundation Australia has for people living with bronchiectasis. We've touched on, you know, a couple, but including educational webinars, digital fact sheets, and the bronchiectasis action plan that Lucy mentioned. This can all be accessed through our website or through the Information and Support Centre at Lung Foundation Australia, and the numbers up on the screen. And then finally, as you've heard tonight, Lung Foundation also has some wonderful peer support options, which Estelle talked a little bit about, which are specifically designed to connect people with bronchiectasis right across Australia, including our telephone-based Peer Connect service and our BronchiExcellence online support network. So I'll just close by saying thank you again to everyone who joined us this evening. We really hope you've been able to gain something from tonight's webinar. But just before you close your window, and once we sign off, an evaluation survey will appear on screen, and we'd very much appreciate your feedback. So, so to make sure that we can keep providing relevant content and the best experience for you and the bronchiectasis community at future events. So with that, I'll say good night. Thank you to everybody, and I'll close the session for today.
Thank you, everyone.
Good night. Thank you.
Thanks, everybody.